Hello again. This is part 2 of the 2022 ITE keyword review of commonly missed items. There are 20 more questions to go over in this slideshow. So here we go. All right, Cushing syndrome labs. We got this right 65% of the time, and close to 90% of the country got this question correct. So what is Cushing syndrome? So Cushing syndrome is essentially hypercortisolism. That can be either primary or secondary, primary being a disease of the adrenal glands and secondary being a disease of the pituitary. Lab abnormalities that are common, since it's a disease of too much cortisol, you see both hyperglycemia and hypokalemia. And the diagnosis can be made in a variety of ways. You can diagnose this by 24-hour cortisol testing or something called a dexamethasone suppression test, which those of you who went through a medicine internship may have heard of in the past. It's where a dose of dexamethasone is given and the level of cortisol is measured thereafter. If the level of cortisol remains high, that is how Cushing syndrome is diagnosed, and if the dexamethasone suppresses the cortisol release, then the diagnosis is less certain. FFP indications. So again, we got this right about half the time. The rest of the US got it right about 70% of the time. And there are several times that FFP is absolutely indicated. So in massive transfusion, we use FFP all the time. The reason for this is that when we give lots of blood products, you can get a coagulopathy based on dilution. So lots and lots of red blood cells will dilute out the coagulation factors that we already have. So by giving FFP, we replace those coagulation factors to avoid the dilutional coagulopathy. FFP can be given in severe liver disease. When the liver doesn't work well, factors aren't produced, so we can give them artificially via FFP. We can give FFP for several different factor deficiencies. That's where the factors live, is in the FFP. Bleeding associated with vitamin K antagonists, Coumadin. If something like PCC is unavailable, that is another indication. And then, of course, in plasma exchange, which is a treatment for a variety of diseases. It should also be noted when not to give FFP. So if the INR is minimally elevated in the 1.3 to 1.7 range, usually FFP administration will not help because the INR of FFP itself is around 1.3. It should not be used in volume expansion. There are other non-blood products, such as albumin, that can be better suited for volume expansion. The reversal of anticoagulants when more specific factors are available, like PCC or for factor 8, the recombinant factors as well. And then there's been some literature suggesting that different neurologic or psychiatric conditions can be treated by FFP, which has not turned out to have much credence. All right, hepatic bilirubin excretion. So, not exactly sure what this question was getting at on the exam, but we can just go over the topic a little bit. So, there are really two types of bilirubin, conjugated and unconjugated. When hemoglobin is broken down, it is initially unconjugated bilirubin, and this is bound to albumin in the plasma. It's taken to the liver, and the complex, the albumin unconjugated bilirubin complex, is transported across hepatocyte membranes, and then there are a variety of enzymatic processes which turn the unconjugated bilirubin into conjugated bilirubin. This then is excreted by an active transport process into the bile, and the high levels of unconjugated bilirubin can be due to a variety of diseases, many of which are due to reduced enzymes turning unconjugated bilirubin into conjugated bilirubin. So we see this in diseases like neonatal jaundice, Crigler-Najjar, and Gilbert syndrome. Hepatic synthetic function labs. So we got this right half the time. The rest of the U.S. got it right a little bit more often. So in acute liver dysfunction, we often see coagulopathy, and this is one of the best ways to determine the synthetic function of the liver is by coagulation labs. So the liver produces many of the coagulation labs, and different factors have different half-lives. So the factor with the shortest half-life is factor 7. This has a half-life of about 4 hours, and fibrinogen is one of the factors with a longer half-life, and the half-life of fibrinogen is about 4 days. So the PT-INR is a very sensitive measure of acute liver dysfunction. Now, for chronic liver dysfunction, the best measure is by albumin. The half-life of albumin is about 3 weeks. So in chronic liver disease, we'll see that folks have low levels of albumin just because it sticks around for a little bit longer. AST, ALT, LDH is a good measure of the cellular integrity of the liver, but not such a good measure of the synthetic function of the liver. So that's important to differentiate. All right, the next key word that we have is IgA deficiency and transfusion risk. So in folks who are IgA deficient, these people often develop anti-IgA antibodies that are present in the plasma. And a transfusion reaction can occur with relatively small amounts of being exposed to relatively small amounts of IgA that are typically in the plasma. But we can also see this reaction with other types of blood products as well. And the reaction that we're concerned for, of course, is anaphylaxis, which we have labeled right here on the right. So in people who are known to be IgA deficient, blood products should really be used with caution and should be screened for anti-IgA antibodies before administering them. And of course, anytime an IgA deficient patient receives a blood transfusion, we should be ready for a potential anaphylactic reaction. And of course, blood products should only be given if absolutely necessary to people with this problem. Our next keyword is lung compliance calculation. This is a very hot topic on the basic exam because the basic exam loves physiology, especially lung physiology. So compliance is defined as a change in volume over a change in pressure. So there are two ways to look at this. A very compliant lung might be like somebody with COPD, when a change in volume requires relatively little pressure. If you compare that to somebody with restrictive lung disease, change in volume will require a higher change in pressure. So change in volume over change in pressure, that you just have to memorize. There are two different types of compliance. One is called static, one is called dynamic, and they measure different parts of the tracheobronchial tree when speaking about compliance. So with static compliance, that implies that air is not moving, and you measure this at a plateau pressure rather than a peak pressure. This is used for measuring only certain parts of the respiratory system. So this gives special consideration to the lung parenchyma and chest wall compliance. Compare this to dynamic compliance, which means compliance when air is moving through the lungs. This is measured with peak inspiratory pressure rather than plateau pressure, and it takes all components of the respiratory system into account when measuring it. It includes the airway, the circuit, the breathing tube, as well as the chest wall and the lung parenchyma. Our next topic is something particularly near and dear to my heart because I am an insulin deficient person, and the physiologic effects of having that insulin deficiency. So it may be obvious from the get-go, if you have relatively little endogenous insulin, you'll suffer from hyperglycemia. But I am willing to bet that that wasn't what they were asking on the exam. Hyperglycemia can lead to other physiologic effects that can have really serious consequences. So what hyperglycemia can do is it can contract the extracellular fluid volume. So since glucose is an osmotic agent, it can draw fluid from the extravascular space or into the vascular space. This can eventually cause hypotension after the fluid is cleared from the body. Also, you can have decreased sodium and potassium levels, meaning the total body sodium and total body potassium. Serum levels of potassium can sometimes be high because folks who are hyperglycemic tend to be acidemic, which can draw potassium out of the cells into the vascular space. So your serum potassium may be high, even though your total body potassium is very low. Hyperglycemia can lead to catabolism of protein and fat. This essentially is when your body uses itself for fuel, since it can't use glucose as it normally does. And this process will cause ketone body formation, which can also lead to ketoacidosis, which is a big issue and can sort of be a circular effect. Our next keyword is calcium release at the neuromuscular junction. So this keyword describes how action potentials are transmitted down the neuron and turn into muscle movement. So when the action potential comes down the neuron and arrives at the terminal portion of the axon, calcium channels allow calcium ions to come into the neuron, which causes then neurotransmitter containing vesicles to release their contents into the neuromuscular junction. This neurotransmitter is acetylcholine, which then diffuses across the cleft, binds to nicotinic acetylcholine receptors, and this causes sodium ions to enter the muscle cell in exchange for potassium ions, which exit the cell. And this process causes depolarization of the muscle cell, which ultimately causes movement. This then spreads across the surface of the muscle, and this ultimately leads to a localized muscle contraction and ultimately a larger muscle contraction. All right, central versus obstructive sleep apnea. So it's important to differentiate these two types because even though the end result is the same, there's an apneic episode, how you get to the apneic episode is somewhat different. So obstructive sleep apnea, as you all know, is when tissue actually obstructs the oropharynx and doesn't allow for the passage of air. Central sleep apnea refers to the central drive to breathe. And this occurs with interruption of signals from the brainstem to the respiratory muscles. So a great deal of things can cause central sleep apnea, but it's also a little bit more challenging to treat than with obstructive sleep apnea. So things like polio can cause central sleep apnea, cervical spine surgery where there's an injury to the brainstem. Different neurodegenerative illnesses such as Parkinson's disease can have a component of central sleep apnea. Different encephalitis conditions, and then of course medications can blunt the brainstem response to elevated CO2, which causes the drive to breathe. In layman's terms, this is described as restless sleep, but not necessarily associated with snoring, frequent waking up at night, and long periods of apnea. I won't go into the exact diagnosis of sleep apnea with the numbers of apneic episodes in a given period of time and things like that, but this is the main idea behind central versus obstructive sleep apnea. Next keyword is TEE, left atrial appendage. So we did pretty well on this question, so I'm not too concerned. This picture here represents a mid-esophageal two-chamber view. So at the top of the image we have the left atrium, the bottom of the image we have the left ventricle, and in between is the mitral valve. Now the little chamber to the right side of the screen is the left atrial appendage, and when we go up to give sedation for TEEs in the echo lab, this is often the focus before they cardiovert. The left atrial appendage is often where clot will hang out in people with arrhythmia like atrial fibrillation. And before cardioverting, we have to make sure that the left atrial appendage is clear of any clot so that it's not dislodged and to cause stroke. As we said here, this picture is a mid-esophageal two-chamber view. This is where the left atrial appendage is best viewed, although you can get modified mid-esophageal two-chamber views to show the complete left atrial appendage. And the last point I used here, as I'd already mentioned, we have to take a peek here before any cardioversion, unless they're anticoagulated, of course. All right, our next keyword is TURP solutions and blindness. So this overall was a pretty tough question. Only about half of the country got this one right. Essentially, there are lots of different solutions that are used during TURP procedures, and there really is no perfect solution out there. They each have their own issues, but one of the more tragic complications from a TURP solution is blindness. So this can be caused by glycine. The glycine is often not necessarily at our institution and not too much anymore due to this complication, but once upon a time it was used often. And large amounts of this can be absorbed and lead to central nervous system toxicity. It can cause encephalopathy, blindness, as we've already mentioned, and also ammonia toxicity, which can form a picture of encephalopathy as well. Up here is a picture of what exactly they do during a TURP. You can take a peek at that as well. All right, fluid management and burns. Again, about 4 out of 5 of us got this one right, which is pretty good. Everybody in the country did very well on this question, but it's worth reviewing. Fluid management after a major burn is calculated by using the Parkland formula. This is 4 cc's multiplied by the percentage of body surface area burned times the weight in kilograms. So if, for instance, a 70 kilogram person had a 20% burn, it would be 4 times 20 times 70. And then half of that solution is given in the first 8 hours, and the second half of that solution is given in the next 16 hours. So this is the amount of fluid that's usually replaced within the first 24 hours. After that, clinical endpoints are used to guide fluid resuscitation. So you want urine output to be maintained at least 0.5 cc's per kilogram per hour. You want to maintain a perfusing goal MAP, at least greater than 60. And you can follow lactate and mixed venous oxygen saturation as well to guide further fluid resuscitation. All right, our next keyword is laryngeal nerve injury. This mostly, the biggest risk of this is in thyroid surgery, and the recurrent laryngeal nerve is the portion of the laryngeal nerve that's of most interest. Injuries in thyroid surgery are usually unilateral, although bilateral nerve injuries can occur as well. So what happens during a unilateral nerve injury? The vocal cord assumes a paramedian position of the ipsilateral cord, and this can cause hoarseness and sometimes stridor. If there's a bilateral injury, this can lead to aphonia and unfortunately a possible airway obstruction. It should also be noted that if you completely sever the laryngeal nerve, it often will assume a paramedian sort of open position, which is less likely to lead to complete airway obstruction. An injury is more likely to lead to complete airway obstruction if it is a bilateral injury. All right, our next keyword is intrathecal to intravenous opioid conversion. So the ratios are different based on whether you're talking about very hydrophilic opioids or very lipophilic opioids. And whenever you're talking about neuraxial opioids, it's very important to consider the hydrophilicity or lipophilicity. So very, very hydrophilic opioids, meaning they, like water, work primarily through a direct spinal effect. So they are injected into the either intrathecal space or epidural space, and they hang out there. There's very limited systemic absorption. Now contrast that with hydrophobic opioids like fentanyl that work primarily by a supraspinal effect, which means that quite a bit of what you inject is systemically absorbed. So the ratios of intrathecal to intravenous opioids are a little bit different based on this characteristic of the opioids. So with very hydrophilic opioids, the ratio is about 1 to 10. So 10 milligrams of IV morphine is equivalent to 1 milligram of epidural morphine, which is equivalent to 0.1 milligrams of intrathecal morphine. So 10 times less, 10 times less. When you talk about an intermediate opioid in terms of hydrophilicity, the ratio is about 1 to 5. Dilaudid is a perfect example. So 1 milligram of IV Dilaudid would be 0.2 milligrams of epidural Dilaudid, which would be 0.04 milligrams of intrathecal Dilaudid. Then if you look at a very lipophilic opioid like fentanyl, 100 micrograms of IV fentanyl is equivalent to about 33 micrograms of epidural fentanyl, which is equivalent to about 10 or so, 6 to 10 micrograms of intrathecal opioid. So remember, always depends on this characteristic of opioids, how attracted it is to water or fat. All right, our next keyword is the differential diagnosis of shock states. This is sort of a very broad topic, and I'm not sure exactly what the question was on the ITE, but about half of us got it right. So I'll just sort of very briefly go through the 4 most common types of shock and what preload, SVR, and cardiac output look like. Another way to think about preload is wedge pressure that you would get with a swan, which also estimates left atrial pressure. So in cardiogenic shock, this would be high, meaning that the heart does not or is not able to pump blood forward. So the preload is very high, and the cardiac output backs up into the lungs. As a compensatory mechanism, the SVR is very high, and of course the cardiac output is very low due to the weak heart. Distributive shock, a good example of distributive shock is sepsis, where there's vasodilation. The preload here is low because all of the intravascular volume is camping out in the vessels. The SVR, by definition, is also low. Sepsis dilates blood vessels, so your systemic vascular resistance is low. Then, as a compensatory mechanism, cardiac output in the setting of somebody with a good heart is high. If somebody also has heart failure or low ejection fraction, this can make distributive shock even worse because the cardiac output can't make up for the low preload and the low systemic vascular resistance. Hypovolemia is another type of shock state that we often see in trauma. So here preload is low because of bleeding or other reasons for hypovolemia. As a compensatory mechanism, SVR is high. The blood vessels try to constrict to maintain a blood pressure. And of course, since the preload is low and our general intravascular volume is low, cardiac output will also be low. The last type of shock is obstructive shock, meaning that cardiac output is blocked at some point. So the most common example of this is pulmonary embolism. So that will allow the heart, or cause the heart not to fill well, so your preload will be low. As a compensatory mechanism, your SVR will be high to try and maintain a blood pressure, and then cardiac output due to the low preload will also be low. So pretty much by knowing this table and thinking about what each of these things mean, you should be able to answer pretty much any question about what type of shock state is in question. All right, so tumescent liposuction and lidocaine dose. So this is very interesting. I actually saw a case of lidocaine toxicity just a couple of weeks ago here in same-day PACU. It was about 8 o'clock at night. The patient had had their procedure early in the day, and they were just about to go home. They were in their street clothes, and they started to exhibit a couple of symptoms of lidocaine toxicity. They had a funny taste in their mouth, they had a little ringing in their ear, and it's a good thing that I had made this slide, because that was the first thing that I thought of. So during tumescent liposuction, a patient is given very, very, very large doses of very, very dilute lidocaine. And the purpose of this is to make the tissue that they're working on very tense, and so that they can use their machines to remove the fat cells. So the maximum safe dosage of lidocaine is estimated to be between 33 to 55 milligrams per kilogram of lidocaine, which is far above the usual teaching of 7 milligrams per kilogram of lidocaine intravascular injection. As I said, the mixture is extremely dilute, and it's given with dilute epinephrine, usually 1 to 1 million epinephrine as well, to constrict the blood vessels to lessen the amount of systemic absorption. As I said, the time to toxicity, if it tends to occur, tends to be delayed due to the vasoconstriction from the epinephrine. And lidocaine, of course, is metabolized by CYP3A4. You can see this graph down here that shows the plasma levels of lidocaine and the different time in hours that this happens. So the peak plasma concentration of lidocaine is somewhere around 12 hours, and then it comes down. So with this patient that I saw in the PACU, we decided to keep her overnight, keep her on a monitor, and she was discharged early next morning because her symptoms of local toxicity had gone away. All right, our next keyword is uncuffed endotracheal tube leak pressure. So for those of you who've done pediatrics, you may have encountered uncuffed endotracheal tubes. Most of our staff, pediatric staff here now, doesn't use uncuffed endotracheal tubes because, as the last point here on the bottom says, there have been multi-center studies that have shown that rates of stridor have been equal between cuffed tubes and uncuffed tubes, and cuffed tubes are a little bit more user-friendly because there are lower rates of tube exchange, as well as easier use of end-tidal CO2 monitoring. So when you place an uncuffed endotracheal tube, you have to determine the pressure at which you get a leak. And if the pressure is too low, usually less than 20 centimeters of water, it's just that. You have a leak, and it makes using that endotracheal tube very challenging. If you have to generate at least 40 centimeters of water of pressure in order to obtain a leak, it means that the uncuffed endotracheal tube is probably too tight, and you're putting your patient at risk for tracheal injury, swelling, and ultimate stridor when you remove that endotracheal tube. So after you place an uncuffed tube, it's really important that you try to get a leak between 20 and 30 centimeters of water of pressure. This question shows up quite often, even though uncuffed tubes are really sort of going out of style. All right, our next keyword is brain death and cardiac dysfunction. So After brain death, cardiac dysfunction is an extremely common occurrence, and this is due to a variety of reasons. One theory is that after brain death, the body experiences a surge in catecholamine, which can lead to direct myocardial injury and subsequent dysfunction after legal brain death. Intracranial hemorrhage, stroke, and other brain injury are often associated with other EKG abnormalities and injury to the myocardium as well, which can lead to cardiac dysfunction. So anytime you have injury to the brain, think that cardiac dysfunction is right around the corner. You can see this is a hard topic to understand. Only about half the country got this question correct. It's talked about a little bit, on rounds in the trauma ICU as well, but it's a good concept to understand. All right, bleeding treatment of Jehovah's Witness patients. So it's important to know that people of the Jehovah's Witness faith will often refuse blood products of any type, which can make caring for them during major surgery somewhat challenging, although there are some things that we can do to try and lessen that challenge. So pre-op, it's always wise to have a discussion with the patient about which, if any, blood products they will accept, including albumin. It's also important to discuss whether they might accept the use of a cell saver, which is really sort of an auto transfusion. Some folks believe that this is in violation of their beliefs, while some are willing to accept this. Also, if large blood loss intraoperatively is expected, you can have the patients on a pre-op iron regimen or EPO regimen. Intra-op, there's some things we can do as well, both from an anesthesia standpoint and from a surgery standpoint. I already mentioned cell saver if possible, though some people will not accept this. You can do larger procedures in a staged sort of way. You can use some other drugs that will affect coagulation, such as TXA. And then there are other surgical techniques which can lessen blood loss, such as balloon occlusion devices and others. Ocular effects of radiation exposure. So this one's fairly straightforward, although we don't talk about this too awfully much. So the big risk of prolonged radiation exposure to the eye is the development of cataracts. There are some papers that I found when I was making this presentation about anesthesiologists being compared to interventional radiologists in terms of damage to the eyes, which for folks who work routinely in interventional radiology suites as anesthesiologists, it's almost found that the rates approach that of the interventional radiologists. So as always, it's important to follow your radiation safety guidelines and wear lead and safety goggles if you have them, and that will lessen the risk of cataract formation. Okay, thanks for listening. That's the end of the presentation. If you have any questions at all about this, please seek me out and we can talk about any of these topics. Talk to your attendings, talk to each other. Again, you guys did overall pretty well on the ITE. I don't want you to take this presentation as the idea that you didn't do well. I think it's just a good opportunity to look at some of the places where we can do better for next year. Thank you very much for listening. Have good days.